this session by thanking Jyoti Madam and the entire ISMPO team for giving us the opportunity to discuss rare case on melanoma, which goes to the theme of the conference. I'll start sharing my screen. Dr. Balaji, I believe, is there.
Yes, ma'am.
Yes. Now I welcome all the panel members onto the stage and looking forward for a good discussion. Balaji, you can go ahead.
Yeah. Good morning, one and all. And I'll be presenting on a very rare case on melanoma. So we got a patient who presented to our daily routine clinical practice. She is a 46-year female, perimenopausal lady, P2L2, no comorbidity, evaluated for vulval lesion and heavy menstrual bleeding in December 2020. And biopsy from the lesion, which was suggestive of invasive melanoma, 5 mm breast low thickness, ulceration present, T4B, invades reticular dermis and Clark's level 4. Mitotic rate is 20 per millimeter square. Foci of tumor necrosis is seen. Non-brisk TAL, absent microsatellite, LVI and neurotropism were absent. Tumor regressions were not seen. The biopsy is positive, ISC is positive for S100, Melan A and HMB 45. So baseline workup CT pelvis has been taken, which suggests of multiple uterine fibroid, vulval lesion seen, and no pelvic lymph node. PET CT done as a staging workup. So this is the baseline.
So Dr. Niveda, are you there?
Yes, yes.
Yeah. Can you just elaborate? Can you take up this session?
Yes. So on CT and the PET CT, I see that there's a some FDG avidity in the region of vulva. So CT just shows a non-specific lesion, and there is avid uptake. And as already mentioned, the uterus is not discernible from the multiple fibroids, which are definitely not taking uptake. So definitely there is some FDG avid uptake in the vulva. So that's what I can say over here.
Okay, Doctor. Sorry, you can go ahead, Dr. Balaji.
Yeah, ma'am. Thank you. So she has been subsequently taken up for total abdominal hysterectomy and bilateral salpingo-oophorectomy. Wide local excision of the vulval lesion has been done. Pelvic lymph nodal dissection and node lymph nodal excision, that is left inguinal node sentinel nodal dissection has excision has been done. So histopathology, skin that is vulval, suggestive of malignant melanoma, which is superficial spreading time, and it is multifocal lesion. Left labia measuring 3.5 into 2.5 into 1 centimeter, and right labia 1.8 to 1 into 1 centimeter. It is 5 mm thickness, 9 mm ulceration, involves the reticular dermis. Mitotic rate is 27 m per millimeter square. Margins were free. Neurotropism present and brisk TAL, no lymphovascular invasion, no tumor regression, no microsatellite. The BSO specimen, there is no evidence of malignancy. Inguinal sentinel lymph nodal, there is no tumor present, and left pelvic lymph node excision, one lymph node is involved by the tumor.
So, Dr. Bharat and Dr. Niveda, as we see, the current AJCC system, edition now demands a lot of detailing in melanoma, and lots of prognostic factors are being coming up. So that clinicians all are very eager to look what is there in the HPR report. So, Dr. Bharat, could you just elaborate on the TIL significance and LVA, neurotropism, etc.?
Thank you very much for the opportunity, and I think you've already illustrated all the important points that form the part of the reporting. Apart from the typing of the melanoma towards the ulceration and the tumor infiltrating lymphocytes, because we are in the era of immunotherapy and we need to furnish this information. Mitotic rates, LVI. We give Clark's classification 1 to 5 in breast low thickness, because these have prognostic connotations associated with these. So these are all prognostic markers, and there can be to some extent a predictive effect also if we have parameters like TILs. If we can mention that there is an immune response in the form of tumor infiltrating lymphocytes as a part of the reporting system. So that's what we are doing and trying to reinforce a reporting format across melanomas that we report in Melanoma Clinic. And I thank Dr. Jyoti for spearheading this, and we're trying to reinforce a uniform reporting pattern in melanomas, which has prognostic and predictive importance.
Dr. Nevda, do you want to add some points to the pathology?
I think a very clinically judgment also, like we add in that in the gross also, like that typical mnemonic A B C D E, the asymmetry, border, color, diameter, which all suggest the progression of the growth of the tumor will add to the gross of the tumor also.
So, Dr. Akhil, I believe you are there. Dr. Akhil?
Dr. Lakshmi, can I add one more point quickly?
Yes, yes, sir.
Yeah, so I think apart from our diagnosis with HMB45 S100 and melanoma, the markers that we follow on for diagnosis of melanoma, especially when it's a melanotic type, now we're in the era also the vemurafenib. So BRAF is one good marker, V1, that is a good substitute towards BRAF mutation, and of course we triage cases for mutation testing mostly as much as we can. So mutation testing is very crucial. And BRAF is a good trade-off IHC marker that we use, the V1 clone for BRAF. That's an important add-on I just want to make a mention. Thank you.
So do you routinely go ahead with BRAF IHC at this point of time?
Yes, we recommend because in terms of the logistics, we might not be able to have our patients triaged as much as we would like to for the mutations, that is the BRAF mutations, NRAS, and the c-KIT, all three mutations that we do. And of course, TMB is also very good, tumor mutation burden for especially if you're contemplating immunotherapy. But BRAF antibody is a good substitute, V1. And we suggest as a separate requisition if the patient can have that. That will be helpful for the contemplation of the vemurafenib if you guys are thinking about it.
Dr. Akhil, anything to add from the clinical side at this point of time? How do you look at this? There are no LVI. So just to summarize the points, mitoid rate, we use a hotspot technique. TIL is, as per the recommendations, we should report it as absent, non-brisk or brisk. It carries a much more favorable prognosis. LV and neurotropism are bad. So now we have a T4B disease, N1, post-staging, 3C disease, no disease elsewhere. So Dr. Akhil, what would you do at this point of time after the surgical exercise is over in this patient? Dr. Akhil? I think he's only medical oncologist at our side, so discussion won't. Is Dr. Akhil there? Akhil Kapoor?
Ma'am, till he joins, can you pass on to questions to some another panelist?
Okay. Because we have only one medical oncologist at our side, that's what I believe. So, passing is...
I think Dr. Jyoti is there. I think she will be, good to answer.
I can pitch in. So I'm sorry, I'm jumbling up between many things. Last day, last minute of, many other issues as well. So please repeat your question, Lakshmi.
Yeah, madam, we have a stage 3C vulva melanoma T4B N1 by its composite staging 3C, post-surgical resection, no other disease, role of adjuvant systemic therapy at this point of time, and what all molecular tests do we? I think Dr. Bharat has already narrated a few points on molecular testing.
Sure. So I think, in the current era, definitely adjuvant therapy has come into a large manner, and we should consider, because melanoma is essentially a systemic disease, and especially the disease which is node positive carries a high recurrence risk. So we have to be really vigilant, and in the short span of time, disease can recur and it can metastasize all over. So right now, as the trials are, running and they are showing their results, the therapy, the adjuvant therapy is coming to earlier lines, earlier stages as well. So stage 3, definitely there is a role of immunotherapy as well as targeted therapy if it is a BRAF mutant case. So both these therapies are has shown promise in various trials, and it is recommended, especially 3B, 3C. It is more incremental benefit in comparison to 3A, but we definitely need to discuss this point in clinics.
Yes, ma'am. So,
and also, I would like to mention that we need to bring into more and more clinical trials in India, because these drugs are life-saving. However, they are pretty expensive, and Fortunately, at present, we are running pembrolizumab stage 4 trial in TMH, with which we were able to provide several melanoma patients the free of cost 2 years standard of course pembro. But that is not the case elsewhere. So we have to be really, for it to bring more and more trials. Thank you very much.
Thank you, madam. Dr. Nevda, which molecular testing would you be comfortable with? IHC, PCR sequencing, or straight away NGS? What do you do routinely in your practice, clinical practice?
If it's pigmented lesion, we usually go for a for molecular for morphology analysis. We go to bleach and then we do a IHC panel of simple S100 melanin and MART if available. We can give a diagnosis of a melanoma. If it's melanotic, also still the same markers work. Then, if as Dr. Bharataki said, we can go for a molecular markers of BRAF, which is IHC is also available. Then, if molecular request is required, then you can offer NGS panel for TERT mutation and whatever it's required for diagnosis for therapeutic.
Yeah, agreed. So for this patient, we have done BRAF, NRAS, and CKIT, which all had turned negative. See, she received pembrolizumab 4 doses from outside hospital as adjuvant. Now she presented to us only 2 months back with progressive, painful right inguinal lymph node. So at performance status 1, she presented to us 5 into 5 centimeter right inguinal node. The PET-CT, which was done in December 2021, showed a high uptake lesion, 54 of SUV in the right inguinal node. A rapidly progressive lesion clinically. Recent CT done 3 weeks in a gap of 3 to 4 weeks shows a rise in the size to 5 centimeter. Progressive lesion, no other lesions on PET-CT still, and the local lesion is still resectable. So, Dr. Nivedita, how valuable or reliable is PET-CT in this situation according to you? These are the PET images of this patient.
Okay, so on whatever images you've provided, I can just see it's a localized high uptake value. So PET-CT for metastasis has a high sensitivity and specificity. We can fairly rely like around 94% sensitive and around 83% specific. So if it's a localized stage, then although melanomas are known to have an early distant metastasis, in this patient it is fairly localized, so we can fairly rely on PET-CT for proceeding.
Okay, so we now have a stage 3 vulvar disease, triple wild type, almost a triple wild type disease, who had received a prior anti-PD-1, still having a resectable local regional lymph node and non-metastatic. So, Dr. Jyoti, madam, how would you like to approach this patient? Would you send the patient for a surgical resection? Anyone in the panel would like to take this question?
Maybe I can chip in with the surgical plan. If it's still resectable on CT scan, on axial CT scan with a good contrast CT, I think we can offer this patient surgical resection.
Yes. So next comes the question whether if we get it fully resected, do we continue with our further adjuvant because it is still non-metastatic, or would you wait for a relapse to have a systemic treatment? That's another question. So anybody in the panel would like to take up? Dr. Akhil, has he joined? So as there are no medical oncologists set aside, can we? The thing is that if the patient had presented with a prior PD-1 failure, so we'll always think in terms of whether it's a pseudo progression or a true progression. In this case, clinically, it was a true progression because there were no inguinal lymph nodes in the prior CT. So that was a new node which is coming up on pembrolizumab. So definitely, we will not consider, if at all we plan adjuvant, we will not consider treatment beyond progression criteria for pembro. We won't be continuing with pembro. Ipilimumab is a different, is another option. So would you do anybody recommend redo mutation analysis PDL1 assay and look for new mutations at this point of time? Dr. Bharat?
I was about to type what we do at TMH when you asked the mutation testing. If I can add, we do CKIT BRAF and NRAS mutations, and I can share with you our data that we've seen. Apart from usually 45% melanoma showing BRAF in Asian population, it is 15 to 25%. We've seen about 16%, 10.8 to 16% cases showing BRAF. And important is that they can show NRAS also. We've seen about 16%, but this particular case was negative for both with the mutations. And if you're contemplating immunotherapy at any point in time, TMB is a good ideal way which you can test by NGS. So that can be expensive. But a trade-off towards that will be if you can see about PDL1 testing, which is not generally necessary, but we can do that PDL1 testing and mentioning about the immune response. So that is what we can do about the PDL1 testing on the tissue sections, and also mentioning about the immune response. But ideally would be the TMB analysis if you're contemplating immunotherapy.
Perfect, Dr. Balaji. Yeah. Because we know there are a lot of tumor inter-heterogeneity within the melanoma, and there are also papers which have come with the data that if you do a mutation analysis in the primary tumor and in the metastatic site, still they differ in each in a single patient, that differs. So all these put together, we can do a radio mutation analysis, especially when the patient is a very young, is in her 40s. It is in her 40s, she can afford. Affordability is not a problem. So definitely we'll go with an NGS. PDL1 assay is not very helpful because as a biomarker, it is not very helpful. But Dr. Nevda, do you want to add something?
Just wanted to know whether NF1 means I've not done it. Tata has experience if this is part of panel of one.
NF1 means neurofibromatosis 1, you are saying?
Yes.
No, we don't have triaging cases for NF1, which is like very rare mutation, which can probably happen. But I don't know how much treatment.
Melanoma panel.
Yes, so that's what I said. NGS can take care of a large, rare, ultra rare mutations, and I think Dr. Lakshmi has very rightly said that they are, heterogeneous and they are high TMBs. So tumor mutation burden. That is, I think, what is one useful thing that NGS can take care of. Identifying a TMB, tumor mutation burden.
I'd like to add one more point, because PDL1 assay can sometimes help in this situation, because from the Checkmate 067 trial, we learned that PDL1 low, less than 1% tumors do good with Nivo-Ipi combination, especially when this patient has failed PD1, Pembro. Nivo-Ipi, if somebody wants to choose, that would be a clue towards whether they would respond. But that is in an initial phase. That's just a descriptive observation and observation point of view. So really don't know whether we can generalize. We can't generalize as of now. For this patient itself, we can have a try. So if somebody if we are planning the patient for surgical exercise, and then we are not going to treat her right now with adjuvant, we would probably wait for a relapse to happen, and then we would treat. At that time, we would definitely do a mutation analysis, and these are the listed options. So there are lots of options now, and obviously clinical trial should be the one way to go ahead for this patient. So any comments? Which option would be better? Yeah, definitely. Any medical oncologist you could give an opinion on this question? So because of lack of time, can I go ahead?
Yes, ma'am.
Yes. Because first option Nivo-Ipi is again an option in this patient. Again, Ipilimumab is an option because prior PD1 failed, all have got responses to these regimens. Pembro, low-dose Ipi and Pembro, Lenvatinib are newer trials, but only phase 2 data is there for patients who have prior PD1 fail, having a response to this combination. Relatlimab, Nivo. Relatlimab is anti-LAG3 antibody, which has recently been published in NEJM, where they have shown a PFS benefit. And of course, when we are targeting this mutation analysis by NGS, you can have NRTK allacross mutation, so that NRTK inhibitors can be given, or ALK inhibitors can be tried once in a while if the patient happens to be so. Chemotherapy, I'm not very sure whether the patient would benefit with the chemotherapy. And of course, clinical trial is the way to go ahead in this patient, equally important, because we know melanoma is one of the diseases where the mutations are so much common, and it's evolving also, so that we have only targetable lesions, targetable drugs in very few. Many of them are ongoing. So if the patient happens to be in a clinical trial, where they can target any agents which can be detected by NGS that would be good in this patient. So right now we have it's almost like a triple wild type, very odd case, young 46-year-old resectable disease, prior PD-1 failed. What is the option? So if right now the patient is planned for surgery, we are awaiting an NGS report from the newer tissue, and then plan systemic therapy when the patient relapses. So this is an interesting point which is published very recently, that is tumor infiltrating lymphocyte therapy, which is an adaptive cell transfer in metastatic melanoma who do not have any other options and have failed all the other lines. In our patient, PD-1 is failed. She does not have a BRAF to be targeted, so she might be a candidate for tumor infiltrating lymphocyte therapy if she can get a chance for that. So just to summarize my points, detailing the pathology is very crucial. Vulnerable melanoma has a very poor outcome. Sentinel lymph node dissection is a staging tool. There is no overall survival benefit. Non-sentinel lymph node positivity is an independent predictor. Imaging we already discussed. Deciding on systemic adjuvant therapy, we have the options listed here, that is nivolumab, pembro, and nivolumab, pembro has been approved for patients who are irrespective of BRAF or PD-L1 status, and the adjuvant systemic therapy now the minimum criteria is 2B. And for BRAF mutant patients, you have the option of dabrafenib and trametinib. So when you consider adjuvant systemic treatment, always consider the clinical benefit, risk, toxicity, and comorbidities and polypharmacy of the patient. Neogen is in the trials, stage 3 unresectable or stage 4 disease. We have the options listed here, pembro, nivo. Obviously, for our patient, both these are not very good. We would choose for a nivo ipi, or with prior, if they are available, ipilimumab, relatlimab, nivo, which had shown a PFS benefit. Again, pembro, low dose ipi, where there are only phase 2 data, 70 patients with, they have quoted a significant anti-tumor activity. Pembro, lenvatinib, only 100 patients, again a phase 2 data showing a response rate of 18%. So, do we have any biomarker guidance? As of now, no. But from the, as I've already pointed out, less than 1% PD-L1 positivity can do better with nivo-ipi, but that is just a descriptive analysis. So, we are dealing with a patient who is almost like a triple wild type. Triple wild type ideally means BRAF, NRAS, and NF1 negative. For our patient, it was BRAF, NRAS, and c-KIT negative, which comes to around 15% of the total cases of melanoma. We do not have ideal guidelines to treat such patients. So whenever we plan on repeat testing, larger panel like NGS is much preferred. So we can check for the actionable mutations. We do know that passenger mutations are there, which definitely will confuse us. But in rare situations, all these NRK, Alcros targets can help us. And if the patient happens to have a mutation which is druggable in any clinical trial, that is also a way for this patient. And last but not the least, very recently, tumor infiltrating lymphocyte therapy is also an option. And cytotoxic agents, I really do not know what is the benefit for our patient. And always palliative surgery and RT helps in many situations throughout the course of this patient. And thank you for your attention.